If you were in clinic with me this morning, I don't think any of the patients I saw had any of these common hand conditions. We saw some like central cord and some radial tunnel. We're not going to touch on any of that today, but we will go over what I think is probably the most common hand, elbow, and wrist. We will have some time afterwards before you do the live demonstration to go over questions you may have, so feel free to write them down and ask as we end this, and we'll go on, and I can answer them before we move on. So I have nothing to disclose, but most of the time when you think about hand or wrist pain, this is kind of what you think about. But hand surgeons, when we think about wrist pain, this is what we think about on the radial side of the wrist, and then this is what we think about when we go to the ulnar side of the wrist, right? So there's a lot of discrete points that hopefully you will get out of this talk today, which will help you discern some of these specific areas of palpation and some of the specific diagnoses that we see, and then kind of think about when you need to have them see a hand surgeon or when you can take care of it yourself. So here's a list of just some of the few things that we see in clinic, but these are probably the most common, and we'll go over them and hopefully give you some pearls to take home. So carpal tunnel, and I think everybody knows, what the diagnosis for carpal tunnel is. It's compression of the median nerve at the wrist, and the nerve usually presents first as pain, then tingling, and then progressive numbness as the nerve is more and more compressed. And everybody typically knows that, you see late stages, you start to see weakness or clumsiness. They say they're dropping objects. They feel like they have objects, and then they look at their hand and they're not holding it. People tend to drop heavy objects. They can't do fine motor skills. Sometimes they have problems buttoning buttons. They can't tell the difference between a quarter and a dime in their pocket. But the risk factors, and there's a lot of them, right? So we know that age is associated with it, genetic predisposition, so it can be hereditary, but we do know that obesity is associated, any high hand-wrist repetition, right? So it is associated with certain work where you're doing repetitive wrist flexion. And then rheumatoid arthritis, occupational exposure, the stuff that's been most studied is vibrational. So anytime I have anybody with jackhammering, I tell them that's certainly qualifies as related to carpal tunnel, work related. And then you do see it in a lot of assembly line work and people that flex. And then you can see on the right that there's associated with hypothyroidism, diabetes, pregnancy, and then there's a lot of random things or rare mechanical causes. So anytime anybody has tenosynovitis or inflammation related to the flexor tendons, I saw a patient with rheumatoid arthritis that had very bad synovitis. And then you can have a ganglion. Very rarely is it in the wrist, in the carpal tunnel, but it can cause compression of the nerve. Persistent median artery, as sometimes we see at the time of surgery, can cause carpal tunnel. And then if there's any aberrant muscle, so sometimes you may see an abnormal lumbrical takeoff, which comes in the carpal tunnel and can cause increased space, like a space-occupying lesion. We do see it associated with a lot of distal radius fractures. The literature says somewhere around 10% that you can see carpal tunnel associated with it. The pathophys is very multifactorial. So we know we see it in diabetes and microvascular disease, can also cause a peripheral polyneuropathy. But when you're thinking about carpal tunnel, you need to distinguish between a compressive and the peripheral neuropathy. And it's usually a compressive is really anatomic, right? So that's why we do the Tinel's test or the compression test or the Phelan's test to see where exactly that compression of the nerve, where is a nerve getting trapped, where is it annoyed, versus the stocking glove that you may see in a peripheral neuropathy. And then oftentimes carpal tunnel may be bilateral, but it's usually varying degrees on one side or the other. They both have a slow onset of progression. And then in peripheral, usually the Tinel's, right? The Tinel's is the nerve is angry. When you tap a nerve, it means the nerve is still annoyed and it's irritated. In a compressive neuropathy, it's often positive. It's not always positive, and I try and tell this to our residents. It's often not positive when the nerve isn't pissed off anymore, right? Remember, that's what a Tinel's is. The nerve is angry. So you can have somebody that has severe carpal tunnel that has a negative Tinel's, but that still has carpal tunnel. The nerve is just I don't work anymore. I've been compressed for so long. So That's oftentimes when we offer an injection as a trial to see how well they might respond to surgery. So the anatomy, remember that the median nerve and the flexor tendons go through the carpal tunnel, right? You can see that on the bottom of the carpal tunnel, you have the bones, right? So if you do have some CMC arthritis, if you have an osteophyte, the trapezium ends up being part of the border of the carpal tunnel, so that can annoy it. The hook of the hamate, right? We often associate like a hook of a hamate fracture with Guillen's canal, because that's where the ulnar nerve lies, but you can see that it's actually the border of the carpal tunnel. So you may also, if you have any injury to the ulnar side, you may have some annoyance of the carpal tunnel. So sensory, I think everyone knows a classic sign. So it's thumb through part of the radial side of the ring finger, always on the volar side, and just the fingertips here. And then the motor, it's medloaf, so the median nerve does the radial side of lumbrical, the opponens, and the abductor pollicis brevis. So they did studies years ago before IRBs were like approved everywhere, where they actually stuck probes. So I trained under Dr. Gelberman, but they actually stuck probes into people's wrists, and they measured the wrist inflection and extension, and they showed that in wrist flexion, the pressure goes up in the carpal tunnel, which is why we put people in neutral and in wrist splints, right? Because we want to diminish the pressure in the nerve. So we know that the conduction decreases as that pressure increases. So diagnosing it, most of it's based on history. And so even the guidelines in the Orthopedic Society say that it's actually a clinical diagnosis. You don't necessarily need an EMG when you have the classic findings. On physical exam, we do a lot of provocative maneuvers, and then we do muscle testing and sensory testing to support our diagnosis. And now the Tennells, you may read about a Tennells, and you'll see a lot of different ways to do it. Is it one finger? Is it two finger? Where are you tapping? Teaching a lot of medical students, when you ask them to point out where the carpal tunnel is, most of the time they point here, right? We're talking about here. I think everybody knows that, but oftentimes everyone and the patients often think that this is a carpal tunnel when they come in to see you. But it's tapping over the carpal tunnel, and it's enough pressure, whether it's one or two fingers, to actually see that the nerve is annoyed. And what it should do is reproduce the symptoms they have, right? So when I do it, I don't say, does this cause tingling in your fingers, right? You have to say, does this reproduce symptoms, or what does this do, right? Because some people will say, oh yeah, I get tingling up to my fingers, or the people that say it's pain, right? That's actually not a positive test. You want to have it reproduce their symptoms. The Phelan's test, and so the actual real Phelan's test, most of the time people see people doing this. Flexing the elbow is actually a confounder, so that's a modified Phelan's. It's this position. So oftentimes when I'm talking to my patients, I'll just flex both of their wrists down like this, and it's negative. You've actually done it for 60 seconds, which is a really long time. But so oftentimes you'll flex them, and then after a while, 20 or 30 seconds, they'll say, oh yeah. And so I usually actually continue my exam or I talk to the history about it. If I get in the first few sentences that they're saying carpal tunnel, sometimes I'll just do this as I'm doing the exam and continuing to talk to them. The compression test, so here's the good news. This is actually the best test to do. All you're doing is pushing right over the median nerve. So this is the most sensitive test to do, and it's literally just pressure right over the carpal tunnel, and it reproduces their symptoms. Looking at the muscle, so what you're doing is you're looking for thenar atrophy. And remember that the APB, which is the muscle that we're looking for, is actually the most radial one. So if you pull your thumb up palmarly, right, so not radially, it's actually palmarly up like this, you're looking at this muscle here. And then we check, and so that's easy to see atrophy. So when you see severe atrophy there, you know it's most likely severe carpal tunnel. And then you check weakness. And so one of the ways that I do it, and we'll go over this, is I have them make an L, right? If you make an L and then they turn their palm up, that's an easy way to get their hand out of their palm, not to the side here. And then 2-point discrimination, so you can use like a 2-point discriminator. Probably most people here don't have them. You can use a paper clip to see how they do, or you can just use your finger to see. Oftentimes in hand therapy, they'll do Sims-Weinstein testing, but most people don't do that in clinic. So nerve conduction, right? We know that you're testing motor and sensory latency to tell you whether the nerve is not conducting properly across the area where it should be. You can also look at the difference between the median and ulnar side. But again, what I said before is that the diagnosis is really a clear history of specific symptoms, right? So if I get all of these symptoms and they're classic and somebody says, I have night pain, it wakes me up, I have to shake my hands, right? I have numbness in my thumb, index, and long finger. If they say things like that, it's classic carpal tunnel. If they have evidence of APB atrophy or weakness here, they have diminished subjective sensation in their fingers, I don't send them for an EMG unless there's some reason why I want to know it. So oftentimes if they have other problems, maybe if they have neck issues, I want to know it. If it's work comp related, oftentimes we have to do it to be able to do the surgery. And then sometimes if there's other confounding things, I will get it to have as a baseline. So when we stage this, mild, moderate, and severe, and so really you can't do this until you have an EMG that shows you that there's muscle atrophy. But oftentimes you will have an EMG on somebody that has mild carpal tunnel and they have 0 carpal tunnel symptoms. And that's relatively normal. If you actually did EMGs on 100 normal people, a lot of people would have mild carpal tunnel. But moderate is really when we start to consider surgery as a must-do. And then severe is when you have to have the discussion with the patient about whether they're going to benefit from carpal tunnel surgery or not. And the way that I think about severe is severe has atrophy. So you look at the hand and they have that APB atrophy there. And they have persistent sensory loss. So if you do 2-point discrimination or if you check it, they just really have subjective sensation that's diminished here. But the way that I think about it is it hot severe carpal tunnel, meaning that the nerve is still annoyed, it still has a positive Tinel's or a positive compression, meaning you tap on the nerve, it's still annoyed, the nerve is still actively getting irritated by something, or is it cold carpal tunnel, right? Because when you have cold carpal tunnel, the nerves just stop working, and it's like, I'm not even gonna start working again if you do surgery. So when I'm thinking about severe carpal tunnel, that's what I think about and have a discussion with the patient. Because the more severe it is, the less and the longer they've had it, the less benefit they're going to get from surgery. So I want to make sure before I take a knife to a patient, they're going to get better. And so that's really when I consider doing a diagnostic injection to say, how much better do you get from this? If you have cold carpal tunnel and pain, the chances are you're not going to get better from surgery by me. Releasing that nerve is already done. It's not annoyed anymore. It's just not going to work. But if you have severe carpal tunnel and a Tinel's and some of the provocative tests, the chances of you benefiting from surgery are good, right? So that's when I use a diagnostic injection to tell them how much, oh, you got better? Okay, then now we can consider doing the surgery. So non-operative night splinting. So all of these asterisks that you see here, they've been shown to be beneficial. Steroid injections, so steroid injections work, and they work in about 80% of people for a year, but then they have return of symptoms. Oral steroids haven't been really proven. And then therapy also, as you can see, it hasn't been proven. There's like studies on both sides of it. So sometimes in therapy, they'll do nerve gliding exercises. So here's that night splint that you'll see. And then here's the injection. So you're going just ulnar to palmaris longus if you have one. And basically that's the way that I inject right there. We can talk about it later when we do the physical exam. And then here's the incision that I make. That's actually a little bit bigger than the incision I make. I do a mini open. Some people do them endoscopically. So long-term failure, as you can see, is if you have any APB atrophy. So muscle strength doesn't usually come back. Sensory does, but muscle doesn't always. And so long-term success is 100% of those with 6 months of relief from an injection usually do well with surgery. So the other compressive neuropathy that you can see that I mentioned before is Guillen's canal. And you can see this is the hand, the patient's hand is the right hand. That's irritation in the ulnar nerve and Guillen's canal, which is just superficial to the median nerve. It's typically caused with like a space-occupying lesion. So you may see a pseudoaneurysm of the ulnar artery. You may see a ganglion cyst sitting there. You can see a hookup hamate fracture with edema around it causing ulnar nerve symptoms. The way we differentiate between ulnar nerve at the elbow and ulnar nerve at the wrist, there's a sensory branch of the ulnar nerve that provides sensation to the back of the hand that comes off up here. So if you're checking somebody and you're not quite sure if it's cubital tunnel, which is by far the more common ulnar nerve irritation, right, that's a good way to check it. Is there sensation diminished up here? If it's not, right, then you think maybe Guillen's canal. But that's really one of the like very rare instances. So de Quervain's tenosynovitis, again, something that we commonly see. So pain on the thumb, the radial side of the wrist, kind of where the thumb meets the forearm. Worse with lifting or repetitive activities. So I think everybody knows you see this in young mothers who have young children, most likely from picking them up or from breastfeeding in the kind of flexed wrist position like this. Tends to be worse at night, but certainly worse with motion. So the tendons on the back of your hand, if you remember from anatomy a long time ago, the extensor tendons go through 6 separate compartments. You can see in the picture here, that's the extensor retinaculum, but it's actually divided into 6 separate compartments there. And the first one, and you can see right here, so here's the extensor retinaculum. The first one here is these are called the outcroppers because they come from the ulnar side of the wrist and they course along over towards your thumb here, right? And so the abductor pollicis longus, extensor pollicis brevis, that's your first dorsal compartment. And what happens is that sheath becomes narrowed, causing pain and inflammation, right? It's kind of the same as the trigger finger pathophysiology is like you have a train going through a tunnel. And either the train's too big or the tunnel's too small and it hits it and it irritates it. And it causes inflammation, and it causes inflammation of the tendon itself, or you can actually end up with like a cyst or a bump in the actual tendon in the extensor retinaculum over the first. So the thick sheath over the tendon shows histologic changes most of the time when you look at it, again, similar to the trigger finger. And when you're looking at it, so it's not always a classic, like when I deviate, where everyone knows kind of what the Finkelstein test is here for that. Sometimes people really complain of nerve, right? They'll say that like it feels like it's burning, it's shooting, and you're like, well, I really thought you're a young mom, it's gonna be, I knew the diagnosis. When I saw your name on the chart and you go in there and they just have really burning sensation. You can see why, because this is actually the radial sensory nerve. So when you look at anatomy, right, here's the thumb. Here, and this is always why it's hard to differentiate between CMC arthritis, which is certainly more common in women, and then de Quervain's, right? So here's the CMC joint. This is where de Quervain's is up here. And then here's that radial sensory nerve, right? And it's always there. In surgery, it's always there. You see at least one branch, if not 2. But that's why sometimes if you see some people that have engorged veins on the back of their wrist, or if they wear a watch on the back of their wrist, they can also have irritation of this radial sensory nerve here. Or that can be more of a presenting symptom for de Quervain's. So again, more common in women, pain at the base of the thumb. Sometimes they have a clunking of the thumb, which is the actual tendon getting kind of stuck. It's very rare that you see that, but sometimes they will have that. So on examination, so if you put the thumb, I always tell my patients, thumb goes in first and then make a fist over your thumb and then relax their wrist. And if you guys do it sitting there, and ulnarly deviate, that actually hurts to begin with. And so the good news is most people have 2 hands, and so you can check both sides. But and sometimes you just know the story when you walk in there and you see a mom and she's breastfeeding and she has a splint on her wrist and you already know what it is. Don't do it more than once. Sometimes I don't even do this test because it is super painful for them. I'll just kind of press over the area and they're tender, or I don't even do it because I know what the diagnosis is. And so treatment is, most of the time, it's non-operative. Occasionally, we end up operating on this. You can put them in a thumb spica splint. You can get them off the counter. You can buy them through Amazon. You can have a therapist make it. You can get them from orthotics, ice, activity modification. So therapy actually hasn't really shown to be beneficial for de Quervain's. The thing that's the most is the steroid injection. There's a lot of ways to do steroid injections in general. But the one thing that in de Quervain's, the goal is to get into the tendon sheath. Obviously, if you all look at your wrist here, you can see that that's a pretty superficial tendon. So the actually biggest risk for this injection is fat atrophy or skin depigmentation. So when I do this injection, most other times I use Kenalog for my injections. For de Quervain's injection, I use Dex because it actually causes less fat atrophy and less skin depigmentation. And the way that you can do this, I actually go right through the tendon all the way down to the bone. So that puts it the deepest potential. And then I'm going on the bottom side of the tendon sheath to try and spread out the injection. But again, when you talk to people about any injection, you should talk about the the risks, which primarily is the fat necrosis and skin thinning. And you can actually see this in a de Quervain's patient. Certainly for any injection, you have to talk about elevated sugars. So in the hand, it's really about 72 hours that I have to warn my diabetics that they need to monitor their sugars for elevated sugars. Some of the literature says even up to 5 days. The corticosteroid, the flare, the literature says it's somewhere between 1 and 13%, like most it's like 1 to 20% and everything. But that's the pain that's excruciatingly painful for the first 24 hours. Typically, it's the body reacting to the steroid crystals. They might think that they have an infection. It does turn red. Typically, what I tell patients is it will go away. Ice, ibuprofen, give it 72 hours, and it goes away. So I have maybe 1 or 2 patients every year or 2 that actually has this reaction, and I've had 2 patients in my 10-year career here that have actually ended up in the emergency room because it was so painful. And both of those patients had 5 or 6 injections done in clinic that day. So the other thing is when you're talking about pregnancy, right, it's all the fluid shifts. It's the same as the carpal tunnel in pregnancy. And it generally responds to splinting and steroid injection. Surgical treatment, again, is a small incision over the affected area, whether it's a transverse incision, oblique, or horizontal. Most important thing is we find that nerve, and then you get that nerve out of the way, and then you divide the sheath. And then you always have to make sure that you find it because there's multiple slips of the tendon. So APL has a couple slips. EPB usually has 1. You have to find them both because APL can have 1 slip. It can have 6 slips. And EPB usually has 1, but it may have 2. So we really have to make sure that we pull on both of them because oftentimes there's a separate subsheath for the EPB that we also need to open up. So complications of surgery, injury to superficial radial nerve branch. You can cause a radial sensory neuroma, which is just terrible. And patients really hate that, and it can lead you down a road of many surgeries and a lot of pain management for a patient. Palmar subluxation of the tendons, very infrequently, and then obviously an incomplete release. Moving on to probably something everybody here has seen, unless you're a pediatrician, which there probably are some of you here. So basal joint arthritis. So we're talking about thumb CMC joint. If you look here, right, this is the metacarpal, here's the trapezium, and I think everybody can see that that's arthritic and most likely painful, but not always the case. So the history, you typically see somebody that complains of opening jars is painful, turning keys, opening doors, carrying a shopping bag, lifting heavy pans, things like that. And oftentimes they're just complaining, you may get a long history of it, like I had pain for a long time and actually then it went away. And we do see that, and because sometimes the CMC joint, the arthritis actually burns out because you burn off the nerve endings. But the anatomy here, so if you look at the metacarpal base and the trapezium, it looks like 2 upside down Pringles. I just gave you a nice picture for reference, right? Like there are 2 potato chips that look like this. Anytime you have a lot of motion in a joint, it predisposes you to potentially developing arthritis. And so on clinical exam, the physical appearance, you will often see this shoulder sign here, right? If you look at your hand, it's more of like a nice curve, but as the arthritis occurs more and you get that osteophyte like you saw in that first x-ray there, it pushes the metacarpal, it lateralizes the metacarpal, and you end up, you can see it here, this osteophyte kind of pushes this out and you end up with what looks like a shoulder, and this is kind of the deformity that you see as it progresses. So on clinical exam, you can see that sign, you can see tenderness. So the specific test, tenderness to palpation over the CMC joint, you may see a positive grind test, which is where you take the thumb, and we'll review this, and you literally grind it into the bone that's painful. And then they look at you and they're like, why did you do that? But it's painful. And so this is the grind test. And I always have to remind our residents, they really need to stabilize. You always want it when you're examining the hand, you want to minimize the joints that are mobile, right? So you really need to make sure that you're actually grabbing the metacarpal, not like the distal phalanx up here or the proximal phalanx. You're grabbing the metacarpal and trying to push it into the trapezium to cause pain. The other test that's not mentioned here is there's a thumb adduction extension test, which was presented in the literature a couple years ago, and I can show you that when we go in. It's also a nice way to diagnose this. So treatment is highly variable for thumb CMC arthritis. Most of the time when you see somebody at first, they're not ready for surgery, or maybe if they've seen you and they've been seeing you for years and you've done injections, and then by the time they see me, they are ready. But most of the time, our first line of defense is splinting, activity modification, therapy, injections. And the splints, and as you can see on this picture here, there are numerous splints. There's the neoprene splint, which gives a lot of mobility. These, while they're great because they immobilize a joint, we are human and everyone wants an opposable thumb. And so this really takes away your thumb motion. So it helps, but then you can't do anything. If anyone's ever worn one of these, I wore one for a day and I was like, this is terrible. We recommend this one a lot, which I have no affiliation with the company, but it gives you a little bit more mobility, and patients tend to like this splint a lot. So we tend to use these two types of splints. And so the activity modification, our therapists help teach them. Sometimes we tell them to switch the grip when they're writing. So instead of holding a pen like this, they put it between their index and their middle finger when they're writing. They get the 3M modifications for opening jars, things like that. And then there's the injections, right? And so injections work best for early stages. You actually still have cartilage that the injection will help with. And in the later stages, I always offer people an injection if they want it. Some people have had very good success with terrible arthritis, but they get an injection once a year, and I'm fine giving them an injection once a year for the rest of their life. But when we inject, so you're going for the base of the first metacarpal, and usually you can actually see the EPB crossing. So you can see EPL and EPB, and it's that sweet spot right in between. You pull a little traction on the thumb, and you can get your injection right in that area. So later stages is when we talk about surgery. And when we talk about surgery, there's all of these options. The CMC fusion is very rarely done. And even less frequently done now because the studies, they actually did a head-to-head comparison recently, and there were so many complications with the CMC fusion, most of them being non-union, that other options have been done. So you can actually cut the metacarpal and do an osteotomy to try and offload it. But, and then there's a resection arthroplasty, which is you just take the trapezium out, or the gold standard is the suspension plasty. So not only do you take the bone out, but then you try and suspend the thumb in space, right, to give it its length and hopefully give it enough strength back. So there are about 85 to 90 good to excellent results with these surgeries. It is a long recovery period. So it is about a year recovery after this. It's almost a year recovery after the majority of hand surgery. Although most get better in the first 3 months, it still does take a full year of recovery. So trigger finger, it's that locking, clicking, or snapping sensation. Sometimes it's actually just pain, which depends on the stage that somebody presents with a trigger finger. But symptoms are usually worse in the morning because, as we know, fingers are more swollen in the morning because you don't have good venous return. And so that's when you wake up and it's most often stuck then, and you have to work it out for a while or run it under warm water to help get that swelling. So you oftentimes we'll also see it in the thumb. In the infantile form, or what used to be called congenital trigger thumb, it was most often noticed after what they call some trauma. So we get referred a lot of kids who have had a trauma to the thumb, and then all of a sudden the parents notice it and they come in and you try and tell them, like, no, they've been like this for a long time, and they refuse to believe you. But then usually once they have an x-ray at some point and the x-ray has been previously done, then you can tell them it's a trigger finger. But most of the time, what I tell my residents is anytime they come to me and they're presenting a patient, I say it's always a trigger finger. When they don't know, I say I guarantee you it's going to be a trigger finger, because trigger finger tends to be that nebulous diagnosis. It's usually when they come and say, I have this really interesting case, and I say, I bet it's a trigger finger. And it usually is. And so the one finger test tends to work the best for trigger finger. So I usually tell people, once you talk to your patients, take one finger and ask them to point where it hurts, right? It usually gives you, if they point here, it's a trigger finger. But it's really pressure right over that A1 pulley. So remember that your fingers go through a tunnel right here, right? They're free, the tendons are free here, and then they go through this tunnel. And that's the entryway to the tunnel, is where you actually get the constriction and the irritation for a trigger finger. And so that's where they're tender. Sometimes they're swollen. Oftentimes, and you may have all seen this, is that although the triggering happens here, they will often complain of clicking on the dorsal aspect of the finger, right? So they'll, at the PIP joint, that's where they say they feel the clicking. It doesn't mean that it's the A2 pulley. It doesn't mean it's the A3 pulley. That's usually where the referred clicking, they will complain of it or note that it's happening. So the anatomy, this is just a reminder that there's nothing covering it. There's the carpal tunnel back here, and then you start with your A1 pulley here. This is a palmar aponeurosis. And then this is why that you can actually bend your fingers, is because you have this lovely pulley system that holds it down to the bone. But this is the problem, and that's all we do is release that right there when we do the surgery. So it is, you can see nodular or inflammatory enlargement of the tendons. The finger can become locked in flexion or in extension, right? Everyone's probably seen somebody that's actually been stuck in extension. And the thumb is certainly the most common, but then it's usually the ring or long finger. Primary trigger finger is the most common, and we usually don't know why. You would think by now someone would have really figured this out, but we haven't. Keeps us in business, I guess. And then it's associated with other diagnoses. So you can see it in diabetes and rheumatoid arthritis. And these are a little bit different entities when we talk to them. They present slightly different. So you get a lot of thickening of the tendon itself in these cases, and so sometimes when we see rheumatoid patients, it's actually a bigger surgery when we're talking about a trigger finger for them. And then the congenital form, as I mentioned, this is usually just an anatomy mismatch, right? So we do go in and release the A1 pulley in kids, and it's most commonly in the thumb. Pathophysiology doesn't matter all that much, but you do see metaplasia of the A1 pulley. And that's the incision. So you may see a longitudinal incision in a patient, you may see a transverse, you may see an oblique. But when we talk about grading system, we don't usually talk about it that much. We say they have a trigger finger, they don't. But just know that there is pre-triggering. So there's pain in the palm, right? They may have a history of catching, but usually when somebody has pain in the palm, it's a trigger finger. And then it goes on. So meaning that they can actively flex and they are actively able to open it. Passively, meaning it locks, they have to use the other hand to open it. And then contracture means they can't open it, they're stuck. Those are the ones we say you definitely need surgery. The other ones we try injections first for. So you can splint, and splinting options are many. Some people like the splint that actually comes over the MP joint in the palm here. It just prevents flexion of the finger, and this is usually worn at night. Here's another one that prevents flexion of the PIP joint at night. Studies show that it works somewhere between 40 and 85% of the time. Another great literature out there in hand surgery. But so it is worth trying if you have somebody that isn't interested in injections, right? Most people do want an injection, but you can try them with splinting first. So the other thing is anti-inflammatories may help. Hand therapists can make those splints for you. And steroid injection is more effective than splints. So 60 to 70% of the time, an injection can resolve with trigger finger with one injection. So lower success rates is most common in diabetics. So diabetics have a much lower success rate. It doesn't mean I won't try them with an injection, but I always tell them that they have about a 40 to 50% success rate. And then if they have other upper extremity tendinopathies, the studies have shown that they have a lower likelihood of success. So injections, I'm sure everyone here has probably done or seen one. You can do them in clinic. The goal, and it depends with it, whether you inject here or here, right? Remember that the tendon sheath goes all the way up the finger. So I actually tend to inject right at the proximal digital crease, right where the finger meets the palm. The A1 pulley is down here. You can look at it if you look at your distal palmar crease on your hand. That's where the A1 pulley is. I don't inject there because, number one, it's actually where the pathology is, and it's probably a little bit more painful. Number two, it's right over the MP joint, so you can end up in the joint. Number 3, it's much easier to find midline at that part of your hand, right? Because it's not coursing in an oblique fashion. It's going right up the middle of the finger. So that's why I do my injection there. Risks of injection, as we mentioned before, we went over these. And then injections in diabetics, as I mentioned. So the greatest the blood glucose increases in the first 24 hours, but it can last up to 5 days. And one of the things that you can see in the image here, when you inject, this is how I inject. I actually go through the tendon all the way down to the bone, same as I mentioned for de Quervain's veins earlier, going all the way down to the bone, getting in this side of the tendon sheath here. And then I just relax the pressure on my needle a little bit, stick my hands on either finger on either side, and then inject. And then that way you can feel the fluid going up and down the finger here. Some people just inject sub-Q. There was a study that showed, one study, it hasn't been reproduced, that shows a sub-Q injection right over the MP joint is as good in injecting the tendon sheath. Surgery obviously is for people that want surgery, that they failed prior injections, that don't like needles. We frequently have that. And certainly in diabetics, it's something that you can talk to them as a first-line defense, but I usually do try an injection first. So this is usually the incision that you see here. It's a relatively small incision, and we just protect the neurovascular bundles on either side. Now that we do a lot of wide-awake surgery in hand, we can actually do the surgery under local with epinephrine. At the end of the surgery, we have the patient flex and extend their fingers, and then you know if they're triggering still, right? If you need to release more. So it's a great way to do it with a patient participating. They stay awake. They don't have to have a whole numb arm. And you can guarantee, you can show them at the end. I'll even drop the drape and say, hey, look at this. And you can see them moving. So complications, you can have bowstringing. It's very rare that it happens, neurovascular injury, or then recurrence or persistent triggering. So sometimes with a recurrent triggering or persistent triggering, you may need to do a more extended release. So ganglion cysts, let's see how I'm doing on time. Ganglion cysts are certainly very common. It's the most common lump and bump in the wrist that you'll see. It's more common on the dorsal side. They're not usually quite this big. I like this picture because it's very obvious for everyone to see. But if anyone's ever aspirated a cyst or seen one aspirated, it looks like hair gel. And it has that thick, viscous fluid. And it may fluctuate in size. And I think everybody knows, the original treatment was like the Bible thump or whatever type of thump you do for it, but that actually can burst the cyst. And remember that it is like a balloon and has a stalk. And so that's why the recurrence rate with surgery is much lower, because we actually track the stalk down. So most of the time when somebody comes in with a ganglion cyst, they either can show it to you, or when they can't, it's the occult ganglion cyst. So the typical presentation of somebody with a ganglion cyst that's not just like, here's my bump, it bothers me, is pain on the dorsum of the wrist and pain with hyperextension. So in San Francisco, what that means is most yoga patients, they say they're doing the downward dog, really bothers my wrist. And so oftentimes, if I can't see it, I'll get an MRI, but I say, I think you have an occult ganglion cyst, and usually they do when you look at it. But it's that hyperextension injury in this position that really bothers them. So one study showed that 10% are associated with preceding trauma. And then the pathogenesis, so it is from modified synovial and mesenchymal cells. And so when you look at it, it's a balloon and the stalk on the dorsum of the wrist usually comes between the scaphoid and the lunate. And so when we do the surgery, we either do arthroscopically or we make an incision. It could be a longitudinal or a transverse one. We find the cyst, we protect the tendons, and we track it down to the bottom. And then we take the stalk out, and then we burn the bottom so that it doesn't come back. So treatment, aspiration has a recurrence rate of 80%. Versus excision, and the open and arthroscopic have a recurrence rate in the literature is somewhere between 10 and 20%. So it's still pretty high. And you can see here, this is kind of a nice picture showing you that we have to track it all the way down here. This is a scaphoid lunate. This is the SL ligament. That's where it's coming from. And then we just burn this a little bit. So mallet fingers. Everyone has probably seen a mallet finger, or it's seen you, and we haven't quite diagnosed it, but there's soft tissue mallets and then there's bony mallets. And it's the extensor mechanism is incompetent, whether it's the extensor itself at the terminal tendon has pulled off of the distal phalanx here, or there's a fracture, as you can clearly see in this picture with this arrow pointed to it. And it usually caused by the finger is in an extended position and you jam it and the tendon pulls off. And so you end up with a finger droop, right? And it's not usually a contracture, it's just what we call an extensor lag, meaning you can passively extend the finger, but the patient can't hold the finger up, right? And so the treatment for it really depends on the time from the injury and the type of the injury. So it's always important to say, if you're referring somebody, you want to say, this is a 2-day-old mallet finger. We do want to know whether it's bony or not, because sometimes the actual size of the fracture itself will determine whether or not it's operative. Or when we look at an x-ray, in this one, it's pretty obvious that this joint here, the distal phalanx, is subluxated volarly, right? And so that is something that we consider surgical, right? And so versus something like this, we just put in a splint and treat them like that. But the timing is important, because the further away from the initial injury, the longer we splint them, number one, and number two is the less likelihood that they have a chance of success. So if you see a 6-month-old mallet finger, right, the chance of us actually getting operative or non-operative success is relatively low. So sometimes they're painful and swollen. And then the bony, the size of the fragment and the concentricity of the joint, like we just talked about, versus soft tissue, and then closed versus open. I think everyone's probably seen somebody or had a friend that crushed their finger in a door, or knew somebody that did that, and they have an open injury. Most of the time, mallet fingers tend to be closed. So splinting, there are a million different ways that you can splint them. This is probably my favorite splint because the patient can shower with it on. But it's very infrequently made. This is actually like a thermoplastic one that you can just put in warm water and wrap around. And it's a little bit of hyperextension. So if you see somebody, and if you have the Alumifoam splints, or if you have the stack splints in your clinic, or if you have a tongue depressor and you can tape it to the patient, that's totally fine, right? What you need to do is get the patient in a neutral position. And then the most important thing, you tell them not to take it off. And you tell them not to take it off for 6 to 8 weeks. And if they take it off, then it starts back at day 1, right? That's the hardest part, is that you have to tell them you own this, and you own this as part of your body for the next 6 weeks full time. And if it slides off accidentally in the middle of the night, you're back at day 1, right? And so that's why you want to make sure it's well fitted, or not only are they splinted, but if you feel like you need to co-band them on top of it to get it to stick to the skin, I would do that. And so I tend to be somewhere between 6 and 8 weeks. It depends on the type of patient I'm treating and how compliant I actually think they will be. And you treat them in extension. And then it's really about education. So if you need to send them to a hand therapist to do the education for you, or if they're making the splint for you, then that's where they get most of their education. But it's really important to tell them, if you want to only wear it for 6 or 8 weeks, you better wear it all the time. Dupuytren's. So how many people in the room have seen Dupuytren's? So a lot of you have, yeah. It's autosomal dominant, variable penetrance. Causes, we don't really know why. We certainly know that there's a genetic predisposition. We know that, if you have somebody in your family that has it, if you have multiple people in your family, the likelihood of you having it worse. There's a Dupuytren's diaphysis, meaning if you get it at a younger age, if you have a family member that had it, depending on your contracture, the likelihood of recurrence is really high. It's associated with a bunch of stuff, primarily Eastern European descent, but all of these things have shown it's multifactorial. They've located it to some genes, some family lineages. Some of the thought is that it's some type of ischemic injury to the hand. They were able to reproduce it in monkeys by causing an ischemic injury to the hand. It has something to do with IL-2, and that's sort of where my basic science ends. But all we know is that you see nodules and cords, and the normal anatomy. So if you look at your hand in an extended position, The normal anatomy is that you have palmar fascia here and it's pretty tight. So with your extended fingers, if you push on it, that's palmar fascia. And it's this nice, smooth, flat fascial layer. And for some reason, it turns into from fibroblasts to myofibroblasts, and it causes cords and it causes the fingers to flex, right? So you get these little nodules and you get these cords. And sometimes when it pulls on the skin, you can see these little pits in the skin. You may also see bumps on the back of the knuckles, called Garrett's pads that you'll see. But what we're really talking about is, progressive flexion deformity of the fingers and thickening of these cords. So way more common in men. What we want to document is where those cords are and what the degree of contracture is, both at the MP joint, the PIP joint, right, and which fingers it's contracting. So that's what we look for is, can they get their hand flat on a table? If not, it's a tabletop test, and that's when we talk about surgery. Any contracture at the PIP joint, so in the fingers, is usually considered potentially operative. And oftentimes the cords are just painful. So we usually say a 30-degree contracture at your MP joint, but actually sometimes patients come in and they just say, it just really hurts when I grab something. And most of the thought behind that is as it rolls up, it might be grabbing a little sensory nerve, or it's grabbing like a Pacinian, like a pressure, one of the Pacinian corpuscles, and that might be why it's painful. So I certainly have taken out a lot more cords that are less than 30 degrees contracted just because it's painful. Treatment is, non-operative splinting therapy. There is the collagenase injections. So the hardest part about the collagenase, it doesn't work with a nodular type. It works with the cords well. It works really well for MP contractures, not so great for PIP contractures. The recurrence rate is about 70%. And so the other option is percutaneous needle aponeurotomy, which is usually an in-office procedure where we numb up the finger, but with the goal to not numb the fingertip up, because remember, there's nerves around that area. And we go in with tiny little needles and we poke and poke and poke and poke and poke at the cord. And then when we think we've poked enough, you try and cut the cord and extend the finger. And hand surgeons usually either have a combination of all of these, meaning we may do percutaneous needle aponeurotomy, collagenase in some cases, and then a fasciectomy, which means a big open incision to take the cords out. The hardest part is telling patients that there's at least a 50% recurrence rate, right, despite all of these things, and it can happen as early as 5 years. So moving on to a little bit of more elbow stuff. Cubital tunnel. So cubital tunnel, as we mentioned before, I talked about it related to Guillon's. It's ulnar nerve compression at the elbow. Everyone's hit their funny bone and know what it's like. But clinically, most people present with intermittent numbness and tingling in the small and the ring finger. And they don't present saying I have intrinsic weakness, but they may say that my grip strength feels like it's less, because remember, most of the hand function is innervated by the ulnar nerve, right? So it's particularly the grip side, being the small and the ring finger side, and then the intrinsics. And so, looks like I forgot the R in this slide, but you will see when you test them, they have some weakness, particularly in the small finger. You may see when you're trying to have them isolate the FDP to the index finger, which we'll go over. They may say that they have some flexion problem, or you'll see weakness when you do a resisted flexion there. Diminished sensation over the dorsum of the hand on the ulnar side because of the sensory nerve that's here. And then diminished sensation in these two fingers, right? So on the volar aspect of the ring and small finger, they'll have diminished sensation there. And typically the history is driving, reading a book, like when you're in bed at night, talking on your cell phone. So those are sort of all of the provocative signs. When I'm talking to somebody, that's what I'm trying to elicit from them. And I literally will say, do you go numb when you're driving, when you're reading a book at night, or on the cell phone? And that usually kind of tells you probably what it is. And then they say it's on this side of the hand. There are a lot of areas where the nerve can be compressed around the elbow, the cubital tunnel being the most common site. So that's the roof of where the ulnar nerve goes between the olecranon and the medial epicondyle there. Osborne's ligament is this roof that you'll see here. This is the medial epicondyle. The triceps, so the posterior aspects of the triceps, can actually impinge on the ulnar nerve as it comes around here. And then the medial intermuscular septum, and if you have a relatively thin arm, you can feel that septum right here. It's a tight band that separates the triceps and your biceps and brachialis. And then it dives into the forearm, and it dives between the two heads of your flexor carpi ulnaris. And so these are the areas that when we are decompressing someone, when we're evaluating somebody for cubital tunnel, that we have to think about decompressing. And let's see. So when you're examining somebody for cubital tunnel, right, it's relatively easy to find the medial epicondyle and the olecranon and the area in between. And as you flex and extend the wrist, you should be able to feel the ulnar nerve gliding back and forth. And not always possible, right? But you should be able to feel it sitting in that groove, and it doesn't slide back and forth, meaning it doesn't pop over the elbow. But if we looked at this room here, about 20% of you may have a nerve that subluxates, meaning that it rides up, bless you, it rides up over the groove, right? So it comes up over the medial epicondyle trying to move anteriorly. Doesn't mean that you guys need surgery, although I can give you my card. I'm just kidding. Totally kidding. But about 20% of you will have a subluxating ulnar nerve. And what it does mean is if you have cubital tunnel and you have a subluxating nerve, then we have to talk about not only decompressing the nerve, but moving the nerve because it's already unstable. And so that's when we talk about having to move it, right? And so what you're trying to do is if I press on that area, if I press on the area where Osborne's ligament is or cubital tunnel, and I flex your elbow up, that's a flexion compression test, and I hold you there, does that reproduce your symptoms? And that's all you're doing when you're driving or holding your book, doing things like that. And so that's what we're trying to do, right? So I will always take, if anybody has ulnar nerve symptoms, I take the elbow through a full range of motion. I feel the nerve, I document whether it subluxates or not. And then from then on, I actually go on to do the compression test. So arthritis can cause it because if you have a little osteophyte in the back of where that elbow, the floor of where the cubital tunnel is, you can end up with some ulnar nerve. So sometimes we see people that have bad elbow arthritis that have cubital tunnel symptoms, or somebody has had an elbow injury, or if somebody has like a pitcher, right, they may have some ulnar nerve symptoms because the floor of the cubital tunnel is a posterior part of the MCL. So the provocative tests, again, you can do with Tinel's, the flexion compression, and then we look at strength. And so when you're assessing ulnar nerve function here, this is the first dorsal interosseous, and everyone probably knows that this is how you check ulnar nerve function, right? You do this and you do this. It's really hard, and it'll be nice if you can check it on yourself or you can check it on your partner. It's really hard to say, like, what is normal strength when you do this, right? I mean, these are pretty weak muscles. And so it's very hard to say, yeah, that's a 5 out of 5. Yeah, that's a 3 out of 5, right? And so one of the ways that I do it is actually the first dorsal interossei, which is the muscle here, is actually the strongest. So it's much easier to actually just check that muscle itself. And we'll go over that when we do the exam, but this is how I do it. So you have the patient, you put, like if I'm examining my own hand, I say point your finger towards the wall over there and hold it there and don't let me push it back. And then you can actually see the muscle firing really well, and it's much easier to check. You can see in this patient here, you can see, that's the muscle that I'm talking about. That's the first dorsal interossei that's totally wasted, right? That is atrophy. You can actually see the atrophy on all the interossei here, right? So this obviously is a much more severe case of cubital tunnel, but this does happen. Right, so this signs, the Wartenberg sign, you can see ulnar deviation of the small finger, like you see in this exam here. You can see other signs, the Froment sign, so they'll get IP flexion when you put a piece of paper in between the hand here, and they compensate for the adductor, right, which is ulnar nerve innervated, by flexing the FPL, which is median nerve innervated. And so someone will try and hold a piece of paper in between their finger, and they flex at the IP joint to do it. So, and then this is that sign, the Massey sign, which is loss of that metacarpal arch, right? Remember that the intrinsics give you the arch. When you look at your hand, it has an arch to it. And when you lose it, it just lies flat. So this is the Froment sign. So this is what happens if somebody has a positive Froment's. So cubital tunnel syndrome and treatment for this is like cruel and unusual punishment. But some people, The braces aren't great. We do know that if people have mild cubital tunnel, they come in presenting that it's only been going on a couple months, they don't have any evidence of atrophy, that you actually can tell them splint it. And most of the cases, so up to 80% of people will get better with 3 months of elbow splinting. The braces for cubital tunnel are like, people take off carpal tunnel braces, elbow braces are 10 times worse. So a lot of people don't really like it. So you can tell them to take a night towel and wrap it around your hand like this. But sleeping with your arm in full extension can be quite annoying, but that does help prevent elbow flexion. You can tell your patients to get the pediatric volleyball knee pads and swing them around and wear them here so that they don't flex up at night. You can tell them to take a washcloth and fold it up and put an ACE wrap around the elbow. So that's frequently what I tell my patients. Patient education, right? Tell them not to like put their elbows when they're driving their car like that, or try and read a book in a better position. The operative management, so in situ decompression, which is most frequently done now, is where we actually just decompress the area where it's most commonly compressed, which is right at the cubital tunnel. Medial epicondylectomy, where you actually cut off a piece of the bone, isn't done all that frequently. Usually the in situ decompression and subcutaneous transposition, where you actually take the nerve and move it anteriorly. Lateral epicondylitis. So everybody has probably seen some type of tennis elbow, and the answer is no, it's not always tennis players, and it's very rarely tennis players that get tennis elbows, but it was originally described by that. It's tendinosis, so it's actually not an inflammatory, it's more of a tendinosis at the extensor origin, particularly at the extensor carpi radialis brevis. And so it's pretty common to see it. It's equal incidence in male and female. Age of onset, 35 to 50. Very little is related to tennis. If you do have it to tennis, that you usually tell them to increase their grip, width on their tennis racket, or get some tennis lessons and do better stroke mechanics, or change your racket. And so most of the time we tend to see it with manual laborers who are using heavy tools, like you can see it in gardeners or doing repetitive activities. It is most commonly in the dominant arm, and it's certainly, as is most hand pathology, it's associated with poor coping mechanisms. So anxiety and depression tend to run hand in hand with upper extremity pathology. So clinical presentation, pain over the lateral aspect of the elbow. So it's really tenderness to palpation right over the lateral epicondyle and just distal. And you can usually find that one spot that drives them crazy. The radiation along the wrist extensors and going distally. They do have some pain with resisted wrist extension, sometime with forearm rotation, and they may have weakness in grip. So in really severe cases, they may have nighttime pain, but we don't often see that. And again, they can have stiffness in the morning related to the swelling. And so when you look at it, and this is just a cadaver photo here, here's the olecranon here, here's the anterior aspect, this is the humerus up here. This is the extensor origin, and what you notice here is that it looks like a big glob, right? That's muscle. This is all the extensors. They all kind of come confluently together to insert on the lateral side of the elbow, but it's really the extensor carpi radialis brevis, which is actually just deep to here. And so usually you make a small incision here. If we debride this and you clean it up, and it really looks like kind of snotty tissue versus tendon is nice and white, and you look for like a tendinosis, which looks a little bit more snotty. I don't have a better way to describe it, but it really does look like that. And so it really causes, it's sequential micro tears that just don't heal. So initially it heals, and then it doesn't heal, and it doesn't heal, and it doesn't heal. And again, it is a tendinosis, not a tendinitis. There's really not an inflammatory component when it gets to that stage. So on exam, you can see here palpating over the elbow for tenderness. If you're talking about distal, think about radial tunnel. You really should only think about radial tunnel if you have excluded everything else. There's not a great test for radial tunnel syndrome, and it's usually about 4 finger breadths distal to the lateral epicondyle where they may complain of radial tunnel, but those symptoms are usually this vague forearm pain. Pain with resisted wrist extension and supination. I usually have them give me the finger and hold it up and see if that's painful. And then certainly you can have the therapist assess for grip strength compared to the other side. This is rarely done, but this was actually a slide from one of my therapists. And so treatment most of the time is like just wait. It takes 18 months, usually gets better, but they don't like you for those 18 months. Limit lifting, repetitive grasping, try some therapy. Again, equipment modification. And so there are several things that you can do. You can splint. Some people will splint the wrist because it's a wrist extensor problem. Some people try the tennis elbow, the counterforce braces. Problem with the counterforce braces is that they oftentimes just put the compression more distal over the radial tunnel, so you may transfer a lateral epicondylitis to a radial tunnel problem. Soft tissue massage, the counterforce, the friction massage tends to help, and a lot of patient education about this. And then there's always, the stretching exercises, which is the isometric stretching and strengthening that you can do, and then the physical therapy. So oftentimes you recommend anti-inflammatories, and then there's that question about the bracing and the injections. In terms of injections, so the way that I talk to my patients about injections, a lot of times they come to you and they just want an injection and they don't care what literature we present to them. The studies aren't great. We do know that the actual injecting steroid, while it may give them temporary relief, it usually extends the course of the disease. So that's why I usually tell my patients, but sometimes they'll say, I had an injection, it worked, I just want another one. So the way that I talk to them about it is, if you understand this, I'll give you an injection. So the other thing we do is we actually needle. So as we give the tennis elbow injection, I will needle the bone to try and stimulate an inflammatory response to get it to heal. So if I debride it, it is a lateral incision, and I maybe do the surgery 2 or 3 times a year. It's not very frequent. What we do is we're going in here and we're looking for that tissue. So not the white tissue, but the snotty-looking tissue, I promise. And you're actually just debriding that area, right? And most of the time it hasn't fully ripped off the bone. Sometimes it is, or sometimes it's just the last 2 fibers of the ECRB that are still stuck to the bone, and just cutting them off makes the patient happier. Medial epicondylitis. Carlin, how am I doing on time? Am I probably done? A few more minutes. I think that's all I have. Yeah, I think this might be my last slide. So golfer's elbow, way less common than tennis elbow. It is another overuse syndrome, and it's on the medial side, the flexor pronator, right? So it flexes the wrist, and it's much rarer. So slight male to female predilection, and again, the same kind of time. But you can see it in repetitive motion. You'll see it associated with smokers or obesity. On the medial side, again, there's a flexor pronator mass, which looks very similar to the extensor. And these are the where the flexors are coming from, so they come off the medial epicondyle. So again, you'll have tenderness to palpation right over the medial epicondyle or just distal. You may see in the setting of in golfer's elbow, you oftentimes can see a concomitant cubital tunnel, because remember, the medial epicondyle, the posterior aspect of that is the ulnar nerve. So sometimes if somebody has really bad medial epicondylitis, they may also have numbness and tingling, or sometimes if they have really bad cubital tunnel and they get enough swelling, it'll alter the flexor pronator mass, and they'll end up with medial epicondylitis. So it's not like it's not one or the other. Oftentimes you do see it together. They have pain with pain with resisted wrist flexion or pronation. And treatment is very similar to lateral epicondylitis. The only thing that's different is there's a much higher risk of injecting medial epicondylitis because of the ulnar nerve being there, right? So if you're going to inject it, what you really need to do, number one, is make sure that ulnar nerve does not subluxate, right, when you do it. Put him in a position and know where that ulnar nerve is before you inject, and then make sure you're anterior going down to the medial epicondyle. So the other thing I always tell patients when I do it is, if you feel any numbness as a needle, like if you feel any paresthesias or zing when I stick the needle in, I'm not going to do it, right? So you don't want that to happen. So again, you can use a wrist brace because it's a wrist flexors. You can take the counterforce brace and flip it around the other side. And again, it's mostly patient education and time. The last thing that I'm going to mention is repetitive strain injury, which is kind of like the low back pain of the upper extremity. But this is the general term for disorders that occur with prolonged repetitive use of the hand or upper extremity. And so that's why you see people that are computer workers, or they're assembly line workers, or gardeners, or techies in San Francisco who have like terrible posture. They're sitting home working on their computers like this. And then they have irritation of the everything. Right? They'll come in with medial epicondylitis and lateral epicondylitis and some numbness and some pain in the thoracic outlet. But that's a nice diagnosis to actually put on a therapy prescription to give to the patients, because a lot of it's postural training and ergonomics, and you want to talk to them about a ergonomic assessment at work, and talking about postural training and core strengthening to try and reposition the shoulders. And then usually once they do that and they have better ergonomics at work, it might isolate to like a cubital tunnel or a carpal tunnel, but it usually helps to resolve many of the other things that you're talking about. Again, this is lots of stuff associated or types of repetitive stress. Mostly it's carpal tunnel, cubital tunnel, and epicondylitis. And then I don't even know if BlackBerry still exists, but it was described originally as a BlackBerry thumb, or gamer's thumb. It was like the Wii wrist for a while when the Wii was really big. And as I mentioned, treatment is mostly ergonomics. So just manage expectations, get them into therapy early, get them the ergonomic assessment. And I think that does it.